Hi everybody. Dr. Dan Rubin here with Ad Hoc with the Doc, coming to you again. It's been 2 weeks since we celebrated Naturopathic Medicine Week, and today I have the wonderful opportunity of sitting with Dr. Gina Berman, who is here as an expert on talking about the opioids and addiction, and really excited to talk about her work that she's doing in Scottsdale, Arizona with Blue Door Therapeutics. And thank you so much for joining us today on Ad Hoc.
Thank you for having me.
Appreciate it. Tell us a little bit about your background, because what you're doing now isn't sort of what you did right out of medical school, correct?
No, after medical school, I came to Arizona to be a resident in emergency medicine. And after that, I was then attending at one of the hospitals downtown Phoenix for 10 years. And I had the opportunity after that time to become the medical director for medical marijuana dispensaries. And so I left traditional allopathic medicine and went in to be the medical director of the dispensaries. And when I was in the dispensary, I got to see patients that I used to see in the emergency room who I really didn't have a whole lot to offer. And these were patients that we used to call in the ER. We would call them doc shoppers or drug seekers. And they were patients who were part of this probably earlier push in the opioid epidemic. And when they would come into the ER, I didn't have a lot for them. If I gave them an opioid, I was continuing to add to the problem. I wasn't giving them any solutions. And if I didn't, then I sent them out to try to find it somewhere else. And so that was really a difficult patient to treat in the ER for both patient and for me. So in the dispensary, I started seeing these patients seeking out cannabis to get off of opioids, and they were doing it really successfully. And over time, I saw more and more of these patients. So what I did was I decided to dive in a little bit further, look at the research, and to see if there was any research or evidence base for what they were doing and how to make it make sense. And so I, along that path, became board certified in addiction medicine, and that was in 2015. Wow. And I found a great deal of research, actually, that supported patients' use of cannabis to decrease or eliminate opioid use. So what I decided to do with that was I said, well, why not just add this to rehab? Why not let patients who are going through opioid rehab use cannabis instead? And it can be medically supervised. You can really do it in a way that will really help the patient get off of everything. And in my due diligence on that, I found that there is a greater need amongst patients who realize that they may have a problem, but don't yet identify as being an addict or needing to go away inpatient. And so that's a long stretch of time. The life-altering event of ending up in jail, ending up in court, losing your job, relationship difficulties, we would like to have patients get help before they have that life-altering event that sends a lot of patients into rehab. And so Blue Door Therapeutics is a medical clinic run by physicians specializing in helping patients get off of opioids. And we see patients who are on really extreme amounts of opioids who are able to successfully and actually rather quickly get off a significant amount of opioids, if not get rid of them altogether.
It's wonderful. So let's get a few things straight. If you're out there listening live, or if you're seeing this pre-recorded, you know that yesterday the opioid epidemic in America was declared a public health emergency. A little bit different than what we thought it might have been declared, and there's some statistics that we should talk about. So we're here today because Dr. Berman and her group at Blue Door are people that are taking action against this crisis. And it's a real-time, day-to-day, in the trenches, face-to-face with people who are part of this epidemic, and they're doing something about it. It's not necessarily politics, it's not policy, it's everyday, feet on the ground, traction, claws in the dirt, doing it face-to-face with people. And I think that it's remarkable. I'm totally enthralled with what Dr. Berman's doing. You have a naturopathic doctor at your group too.
We do.
Yes, that's fantastic. Let's talk about some statistics, because for everybody out there, if you haven't heard the news, it's a big deal, because you told me it's how many people each day die in Arizona?
2 people statistically. And Governor Ducey, about 2 months ago or so, maybe 3 months ago, decided to really start tracking this data in real time. So every week he wanted statistics from the hospitals, first responders, and clinics about number of overdose deaths, the number of doses of Narcan that were given that week, the number of patients that were born with neonatal abstinence syndrome. Okay. So he really has been collecting this data and then has used this data in his opioid advisory panel to come out with some recommendations for the state of Arizona. And so he's really been looking at, and that's where we get the number of about 2 patients per day.
But that's not compared to other states, because
Correct.
How many people nationwide die per day from opioid overdose?
I believe the number is around 170.
170. And I read that the statistics out there is that about every 2 weeks there's a 9/11 happening.
Correct.
And if in the news lines they were talking about if this were terrorist attacks and this many Americans were dying, we wouldn't call it a public health emergency. Maybe it would rise to the level of national emergency. Maybe more funding would be put towards it. Because I read today that what was available in the public health emergency funds was $57,000, which was 2 cents per each person. There's 2.6 million addicted Americans, I believe. What do you think about that? You're out there day to day helping these people, and some people, it's the only help that they really have, I would assume. Is that true?
Yes, it is. There are limited resources to help these patients, and I'll really break it down into that's kind of a fluffy political thing. There aren't enough resources. Like, what does that mean, right?
Totally.
There's
Break
a disconnect between what's happening on a legislative level or an executive level for our federal government and what the patients actually need. And so President Obama, I think, said he was going to allocate $1 billion towards the opioid epidemic, but where did that money go? And President Trump has said he's going to allocate funds. Our governor here in Arizona, Doug Ducey, said he's going to allocate funds, but where do these funds really need to go? And I think at the very basic level of it, you do have to attack the problem at the prescriber, because this is I think you could fairly say, the first medical epidemic that has been generated in the medical community itself. And
say that again, please. It's the first what?
Medical epidemic that's been generated by the medical community itself. These are prescribing physicians who are over-prescribing or maybe not responsibly prescribing opioids. And what that leads to are patients who become dependent on opioids and then are cut off. And then oftentimes will go to the street. Our Surgeon General statistic is that over 80% of heroin addicts started with prescription pills.
Started with prescription for maybe a pain syndrome, or, I mean, obviously that's what opioids are for. Correct. And then, interesting.
Or got it from their parents' medicine cabinet, or got it from a friend, or, I mean, this is something but it starts with a prescription pad. Okay, so we have to really educate physicians. We have to rein in the pharmaceutical industry that's made a lot of money. We can go into Purdue Pharma if you'd like, because that's the maker of OxyContin, and also now the maker of the V-Trans patch, which has been recommended by our governor as a substitute for opioids, which is kind of another side conversation. But we definitely have to work on the pharmaceutical company and physicians and re-educating physicians into responsible prescribing. The CDC in 2016 put out a whole packet of responsible prescribing and statistics and data about opioid prescribing. That was a 40-page document. Most physicians don't have the time to read that or really dive into it so that they can change their practice. And it's hard to change a physician's practice once they've started.
I mean, that's a really good and strong point, especially if you have a high-flow, high-volume practice, you're used to prescribing, a patient's on a medicine that works, and also what other tools may be available to that doctor.
By the time a patient is on an opioid, unless that doctor is not informed or maybe not practicing well, they should have tried everything else first. So at the point that a patient is on an opioid, you should be able to assume that they've been tried on everything else, because that should be a last-ditch effort. I would hope that that's the case. But let's talk about some other things. That doesn't require necessarily a lot of money, educating physicians and reining in the pharmaceutical industry, which that second part is going to be difficult because the pharmaceutical industry has a very strong lobby. But let's talk about patients on the ground and what will benefit them. Patients need resources to be able to see physicians. So when I say resources, they need a doctor that they can go to. They need more than a 5-minute appointment every month. They need support systems such as counseling, and those folks need to be reimbursed for their services. If you look at what the Mercy Care, Medicaid type plans are here in Arizona, their reimbursement rates are horrible for physicians. So a physician is going to see those patients. In order to keep the lights on, they have to see a patient every 5 minutes. It's a matter of volume. So that patient doesn't get the care that they need. Patients coming off opioids, we see them or communicate with them every day for at least the first 3 to 4 weeks that they're going through opioid withdrawal. They need a lot of hand-holding. They need a lot of attention because they're in such a dynamic process.
Mm-hmm.
You can't just say, here, do this, and I'll see you for 5 more minutes
They
next
need
month.
medical oversight.
So we need better reimbursement for the providers, the care providers, both the counselors and the physicians who are taking care of these patients. And especially the most needy patients are going to be on what we have in Arizona called Access or Mercy Care or some type of Medicaid type care. That's where the government can really put a lot of money.
Yeah, and you're boots on the ground. You're doing it. You're sitting there. You're seeing the people. Let's talk a little bit about Blue Door. It's a very unique approach that you have.
Mm-hmm.
Who else around the valley here, or in Arizona, or maybe in the state, or even in the country, is doing something similar to what you're doing? Are there resources out there in other states that you know of?
Doing what we're doing, I don't believe anybody else is doing what we're doing.
You're there. You're really helping take action against the opioid crisis. Let's talk a little bit about some of the ways that what are some of the things that you've found useful in helping to get people off the opioids in terms of, are there nutrition, like do you work on nutrition with them? Do you work on sleep patterns? Do you work on mind-body techniques? What are some of the things that you found out besides just orally, like pharmaceuticals or something?
So from the beginning, the patient's immediate needs are usually mostly focused on the medication management. And so that's weaning a patient off of an opioid or helping them through a withdrawal. And that is very intense for the first few weeks. During that time, we get the patient involved in other services. When the patient first comes in, they're not really open to talking about nutrition and fitness.
Okay.
When you're going through withdrawal or when you're dealing with that, that's really a survival type of situation. And so patients are not really interested in that. But those types of conversations are held till a little bit later. Okay. But we do immediately involve patients in our emotional intelligence program, which is cross-referenced with cognitive behavioral therapy, which is all evidence-based to be shown to help with addiction. We get them involved with our counselor, both in family and in group and individual counseling. And I really want to focus just for 1 second on family. Okay. Patients who come to Blue Door must sign a release of information, or we call an ROI, with the clinic. And that means that if that family member or that support system who went through this process with the patient has a question, if they want to see lab results, if they want to know what's going on in therapy, if they want to attend something, there's not a HIPAA barrier. And that patient needs to have the support system at home, linked with the support system in the clinic, linked with their prescribing doctor if applicable, so that it really takes a village to help, really support that patient so that everybody is talking the same language and knows what's going on. I saw previously, again, in my due diligence of putting together this clinic, spoke with many family members who were so frustrated that their loved one is going through this process, and they were completely left out of the entire thing. They couldn't get a conversation. They couldn't state their concern that maybe their loved one was getting medication somewhere else. One family member couldn't even urge the doctor to check the CSPNP, which is our Controlled Substances Monitoring Program, to follow if the patient was doc shopping. Right. So family is very important. They can come to group therapy. They absolutely meet with counseling. And so that's very important. That started all right away. Patients are also supported with acupuncture, massage, and IV therapy, micronutrient IV therapy, which is run with our naturopath. That's not my allopathic training.
But it's important because they're going through this process, either changing of their physiology. They need certain nutritional agents. They need neural pathways stimulated. I mean, it's probably a really big deal for them to ask for help, number one, and number two, have something taken away from them, although it's being replaced with something good that they've depended on for so long.
Right. And the cannabis is a really helpful bridge to use for patients. It helps with withdrawal symptoms because it kind of acts as a weak opioid, and I can go into the neuropharmacology of it, but it kind of acts as a weak opioid. So it replaces it helps with most of the withdrawal symptoms of opioids, minus diarrhea, which it doesn't help with. But and so it can be a kind of a weak replacement. And the beauty of cannabis is that it, unlike other replacement therapies such as Suboxone or buprenorphine or the Butrans patch, which I mentioned earlier, those are opioids. And so they're going to continue to engage the mu receptor or the opioid receptor, some of the other receptors also, but mainly the mu receptor is what we talk about when we talk about opioids. And so if you continue to hammer away at that receptor, it can never re-equilibrate. And so that really is challenging then for the patient to have long-term benefit of being off of those medications altogether. And they themselves, when you take the patient off of those medications, such as Suboxone, buprenorphine, Butrans, they have to go through withdrawal all over again when they're getting off those medications. Cannabis, on the other hand, lands on a different receptor. And it's not the mu receptor, it leaves the mu receptor alone. Cannabis engages in the central nervous system, the CB1 receptor. And so it allows for the moderation of withdrawal symptoms. It's not going to be as strong as an opioid, but it helps get through those withdrawal symptoms and also allows that mu receptor to re-equilibrate without getting the exogenous administration or taking it externally from a pill or a liquid.
It's wonderful.
And so the cannabinoids that are used specifically in the acute withdrawal period to really focus more on THC, and then as patients go into chronic withdrawal, or as we call it, post-acute withdrawal syndrome, or called PAWS, that can go on for a very long period of time, and those patients are very heavily medicated with cannabidiol, which is non-psychoactive. It's also called CBD, and allows patients to be very functional, but it helps with cravings, helps with pain, helps with anxiety. The sleep hygiene that you talked about is also very important. A lot of patients will use the opioids as a sleep medication, and so it's important to really focus on mindfulness, meditation, acupuncture, and sometimes hypnosis can be very helpful for these patients to learn how to sleep on their own without any medication, which is our goal, because the best sleep is natural sleep without any external help. So we have actually a sleep hygiene group on Mondays. We have our emotional intelligence, which we call Blue Q, which is a play off the EQ. On Tuesdays and Thursdays, we have a mindfulness meditation group on Wednesday, and we have a pain support group on Friday. So that's kind of but sleep hygiene is very, very important.
I mean, thank you. It's wonderful. It's very complete. It makes a lot of sense, and I just congratulations on your success thus far with helping people. One thing to also talk about, and I'm a naturopathic physician, and so one of our highest precepts is prevention. And if people don't start on opioids, they're not going to get addicted to opioids. You talked about how opioids would be more of a last resort for a pain type syndrome. Mm-hmm. I work in the field of oncology, so people tend to have very heavy duty pain, and they do get medicated fairly quickly with narcotics, I understand, especially people that may have what is considered a terminal disease. Mm-hmm. But for some people that don't have cancer, or people that have maybe a milder or less intense form of pain, there are treatments that you can try that may be different than steroids, things that you would see like we do at our clinic. I know Dr. Wade here does a prolotherapy, which can be very pain relieving for joints, maybe even save some people for surgery, which could also keep people off of opioids or away from that. And so often in the non-sort of functional, nutritional, naturopathic medicine world, there isn't that type of care of the patient. And so it's more about symptom control maybe until you can get them to surgery. Mm-hmm. And so I just wanted to bring up the role of prevention, and that pain is a multifaceted symptom that occurs differently in different people. And so a really good discussion with your physician, looking at a naturopathic physician who may approach pain differently and may not just give you a medicine just to take care of it, but may look for the source of the pain and how to solve it as well. Just want to talk about that. And that would be one way to help combat the epidemic, is just by frankly not having them prescribed. I do have to bring up, because you talked to me about it and taught me about it yesterday, what's going on in the valley here. There was an arrest made. Yes. I believe. Could you talk a little bit about that? Are you comfortable talking?
Yes, definitely. There was a company called INSYS, INSYS Pharmaceuticals, and they make a fentanyl product, and they also are working on synthetic cannabinoid products. I'm not sure of any other opioid type product that they're making, but the CEO was arrested yesterday.
Racketeering, bribery.
And then I think also misleading marketing and aggressive marketing of his opioid products.
So I saw a headline today about that, because the story is continuing to develop, that the producer of the opioids was feeding the opioid epidemic right here in Arizona by bribing physicians to prescribe it. Now, fentanyl was made to treat cancer-related pain. That was, I believe, the indication. And the drug that was intended for people with cancer was then being prescribed to people without cancer for their pain syndromes. And so folks, like Dr. Berman said, it's an epidemic that's happening from within the industry. It's the first of its kind that you know of, certainly that I know of too. It's for more. Please, write in with your questions if you have a question, or certainly if you're viewing this after the Facebook Live. Blue Door Therapeutics in Scottsdale, Arizona is a very unique clinic. I'm Dr. Dan Rubin. Dr. Berman, I do have one question for you.
Sure.
Would you come back to Ad Hoc with the Doc and talk to us about cannabinoids in medicine?
Absolutely.
Thank
Absolutely.
You.
Thank you. Yeah.
We'll tune in for part 2. Next Ad Hoc will be 2 weeks from today.